Welcome to the 10-part COB Masterclass created by Alan Horn. Part 1 of our epic 10-part series, Introduction to Medicare COB. Are you ready to see the bigger picture? To grasp the foundational logic that makes everything else click? Absolutely. Look at that roadmap on the clipboard. It's all about Medicare, right? But for us, for real COB pros, it's about dissecting that coverage, untangling those claims, and ensuring precise payments. Every single checkmark, every line item is a potential goldmine for accuracy, for identifying those discrepancies. We're not just scratching the surface, we're establishing the bedrock of your COB expertise, understanding why these 3 pillars are non-negotiable for proper coordination. Ready to build that foundation? Let's get to it.
All right, let's hit the accelerator. Look at this incredible roadmap. We're diving headfirst into the intersection of care and coverage. And trust me, it's as complex and vital as this highway interchange. You see all those lanes, all those vehicles? Each one is a claim, an eligibility status, a policy rule. And our job, our mission is determining the right of way for claims payment. Who goes first? Who's primary? Who's secondary? Is Medicare hitting the brakes or are they flying down the fast lane? That's the electrifying challenge of Medicare COB auditing. And by the end of this series, you'll be navigating these claims like a pro driver. We're not just looking at roads, we're mastering the traffic laws of benefits coordination. Let's get to it.
Buckle up. You're looking at the bedrock, the absolute foundation of what we do, coordination of benefits. What is it? It's that critical process for when a member has 2 health plans, not 1, but 2. Which one takes the lead? Who pays first? That's what we're figuring out every single time. Think of it like this visual. Our member car is cruising along, but then the road splits. One path, maybe the group health plan, heads straight to primary payment responsibility. That's the green light, go, go. The other, perhaps Medicare, often lands in secondary payment responsibility. See that blue arrow? It's crucial. Primacy isn't a suggestion, it's a rule. One plan must pay first. That's the primary. The other? Yep, it's the secondary. No exceptions, no guessing games. And your role as the brilliant auditor? It's right there. You are the ultimate arbiter. You're determining that primacy. You're the one enforcing those commercial and the critical MSP rules. We're talking complex logic, folks. This isn't just shuffling papers. It's deep dives into eligibility, coverage, and who bears the responsibility. That's why we love finding those accuracy errors, because someone has to get it right. The ultimate goal, the finish line, is to review those claims where the client thought they paid as primary, and then you verify. Did Medicare actually, truly, absolutely, without a doubt, should have paid first? That's the million-dollar question we're answering. Are you ready to dive into the rules that make this happen? Let's go.
All right, COB Masters, let's dive into the absolute foundation. We're talking original Medicare, Parts A and B. You must know these inside and out. Look at Part A first, hospital insurance. See it? We're covering inpatient hospital stays, inpatient skilled nursing, hospice, and home health. These are your big-ticket services, right? The really significant stuff. And the eligibility? Automatic if disability or age requirements are met. You hit those criteria, often you're in for Part A. That's a critical piece of information for our investigations. No enrollment hassle, just bam, you're covered for those major hospital needs. But hold on, it doesn't stop there. Flip over to Part B, medical insurance. This is where you get all those everyday, crucial medical services. Doctor's visits, outpatient care, medical supplies, preventative services. Think about the sheer volume of claims that fall under this umbrella. And here's the huge distinction, the logical leap we need to make as forensic analysts. Part B isn't automatic. Beneficiaries must enroll and pay premiums. Did you catch that? They have to make an active choice, a financial commitment. If they don't enroll or they're not paying those premiums, Part B isn't active. That's a huge flag for us when we're evaluating primacy. Are you seeing the difference? Part A often kicks in. Part B, it's an active decision. This is fundamental for unraveling our COB cases. Master this distinction and you're already light years ahead.
We've crushed original Medicare. Now let's talk about the private alternatives, Part C and D. This is where it gets spicy for COB. First up, Part C, Medicare Advantage. This is huge. You see that Medicare health plan offered by a private company? That's your first clue. It means a private insurer is actually contracting with Medicare to provide all those Part A and B benefits. Think about that for a second. It often replaces original Medicare processing. So, if your member has Part C, are they on original Medicare? Nope. This is why we have a specific tracker status for it, 210. If they're in Part C, we're not auditing against original Medicare AB benefits, are we? This flips the script big time. Then we hit Part D, prescription drug coverage. Again, plans offered by insurance companies approved by Medicare. Notice a pattern? Private companies. And what does it cover? Prescription drugs, plain and simple. Now, here's your COB gold. If a member has our client's commercial prescription drug coverage and Medicare Part D, which one is primary for those drug claims? Think fast. The commercial drug coverage is almost always primary to Part D. That's a classic overpayment scenario we hunt down. See how knowing these differences empowers you to pinpoint the right primacy every single time? Private plans make things interesting. You got this.
Let's nail down our core mission. What's the objective of the audit team? Of you, as a COB analyst diving into this data? It's simple, but oh so critical. To determine if Medicare should be the primary payer. That's the whole game right there. Think of it like this amazing data funnel, right? We're taking a torrent of claims data and filtering it down to precision. First, step 1. Do we even have overlapping Medicare coverage? No overlap, no COB mystery to solve here, right? But if we do, then comes the real intellectual heavy lifting, the brain power that makes you a COB master, determining that primacy order. Is it working aged, disability, ESRD, retiree, small employer? You're crunching those MSP rules to perfection. And then, the moment of truth, that glorious green box. If Medicare is primary, and we've determined that with absolute certainty because we are accuracy fanatics, then what? We build those valid claims. This isn't just theory. This is where we create value. This is where your forensic data skills materialize into actionable claims. From there, it's about seamless execution. Claims are exported to the client. And the payoff? The client receives that crucial payment or credit. Your work directly impacts their bottom line. See how every step is interconnected? This isn't just a flowchart. It's our blueprint for financial recovery and compliance.
Let's talk about the absolute foundation of everything we do, Medicare Secondary Payer, or MSP rules. These aren't just suggestions. These are the federal regulations, the law that tells us unequivocally who pays primary and who pays secondary. Get it wrong here, and the entire audit unravels. Look at this diagram. It's like a complex highway interchange, isn't it? You've got 3 critical data points, 3 roads converging, and that big red yield sign in the middle, that's you pausing, analyzing, and making the correct primacy decision every single time. First up, entitlement reason. Are we looking at age? Is it disability? Or the notoriously complex ESRD? Each reason kicks off a different set of considerations. But that's not enough, right? Next, we factor in working status. Is our beneficiary active, still crushing it in the workforce, or have they transitioned into retirement? This one piece of data alone can flip primary-secondary status on its head. And finally, the often overlooked yet absolutely crucial factor, group size. Is that employer a Goliath with 100+ employees, or a robust team of 20+, or a smaller outfit with fewer than 20? Because believe it or not, the number of employees determines whether Medicare even considers itself secondary for certain entitlement reasons. Think about it. A beneficiary 65+, active at a company with 20+ employees, boom, GHP is primary, Medicare is secondary. Under 65, disabled, active at an employer with 100+ employees, bam, GHP primary. But if that same 65+ beneficiary is retired, Medicare's primary, full stop. Or that less than 20 employee group size, almost always Medicare primary, unless we're talking about ESRD's initial 30 months. You see how these 3 intersect? You cannot look at them in isolation. It's a trifecta of data, a complex algorithm you're running in your head to determine primacy. Missing one of these pieces means you're driving right past that yield sign without checking for oncoming traffic. Our goal? To navigate this intersection perfectly every time. We're COB data analysts. We thrive on this layered logic. Who's ready to be a COB master?
All right, let's crush rule number 1.
The working agent, that's our 65-plus crowd. This is crucial for determining who pays first, who pays primary. See that green light? That means GHP, your group health plan, is paying primary. Why? We need two things. First, the employer must have 20 or more employees. 20, that's the magic number. Then, and this is vital, the employee must be active, working, contributing. Both conditions met? Boom, GHP is primary. You got this, right? Now, look at the red light. When does Medicare become primary for our 65-plus working agent? It's when the employer has fewer than 20 employees. See that? The moment it dips below 20, Medicare steps up. Or, and this is a big or, if the employee is retired. Doesn't matter how many employees if they're retired. Are they working? Are they active? No? Then Medicare's primary. See how these conditions flip the script? 20 employees, active status. Under 20, or retired. It's a flowchart of precision. You're navigating these complex rules like a pro already.
Time for rule number 2. We're diving into disability, specifically for those under 65. This is a critical distinction, right? Look at that green light. GHP pays primary. You see it? That happens if the employer has a whopping 100 or more employees. Or, get this, if they're part of a multi-employer group and at least one employer in that group exceeds 100 employees. Talk about dynamic. We love that layered logic. But if that employer has fewer than 100 employees, wham, red light, Medicare pays primary. You're seeing the employee count threshold totally shift who's paying first for our under 65 disability beneficiaries. Are you connecting these dots? You're building that COB brain. This is crucial MSP territory.
Rule number 3. Straight into the heart of ESRD, end-stage renal disease. This one is critical for accurate primacy determinations, and you know the audit team loves getting this right. Check out this 30-month coordination period. It's a hard stop, a precise window where primacy flips. From 0 to 30 months, we're looking at GHP primary. And this is where it gets spicy. It's primary regardless of employer size. Forget the 20-plus for working aged. Forget the 100-plus for disability. ESRD trumps those rules for this initial period. But don't get complacent, because at 30-plus months, like clockwork, it flips. Medicare becomes the Medicare primary. No exceptions, no gray areas, the GHP steps aside. Now, for your start date precision, you're not just looking at when dialysis begins. We're looking for the first day of the 3rd month after dialysis begins. That's your launch pad for counting those 30 months. Don't miss that detail. It's a huge accuracy booster for your claims. Get that date right, and you're a COB legend. Let's go.
This is where we get surgical. We're not just looking at coverage, we're identifying the overlap. See that green line for client plan coverage and that blue line for Medicare coverage? They've got their own timelines, but where they intersect, boom, that's the overlap zone. This is the critical period, the golden window where both plans were active. How do you, the forensic data analyst, zero in on only the relevant claims within this zone? You filter claims using NDOS. That's right, the end date of service. Any claim with an NDOS before the Medicare effective date, get out of here. We don't care about it for this investigation. You're making sure every single claim we look at falls squarely within that shared coverage period. And why are we so precise? Because once you filter down to just those overlapping claims, you can accurately calculate spend since Medicare. This isn't just some vague estimate. This is the hard number, the total dollars the client plan paid after Medicare kicked in. Are you seeing the power of this logic? You're literally isolating the exact spend for coordination of benefits. This is how you find those accuracy errors and truly master COB. Let's go.
Let's talk precision filtering. We're diving deep into Part A versus Part B claims, and this is where accuracy is everything. We're not just looking at claims, we're segmenting them, right? Look at that inpatient logic on the left. To snag those pure inpatient hospital claims, what are we hitting? Exactly. We're filtering for a place of service, a POS of 21. Why 21? Because that's our inpatient hospital code, of course. But we can't stop there, can we? No way. We also need to lock down the type of bill, the TOB. And what are we looking for? 11 asterisk. That asterisk is key. Any TOBs starting with 11.
That's how we isolate those inpatient gold mines. If you miss either of those filters, boom, you've got an accuracy error on your hands, mixing apples and oranges, and we don't do that here. Now, pivot your eyes to the right, to medical. This is where it gets slick. If it's not an inpatient Part A claim, meaning it doesn't meet our strict POS 21 and TOB 11 criteria, then what is it? It's everything else, isn't it? Our instruction is crystal clear. We clear those specific POS 21 and TOB 11 filters to capture all other overlapping claims. See how that works? It's a binary split. Either it's a Part A inpatient hospital claim, or it falls into the vast universe of Part B medical and other services. This isn't just filtering, it's defining. You must understand this fundamental split to correctly attribute spend and identify those critical overlaps. Are you feeling that power? This is how we become COB masters, by knowing exactly which claims live where. Don't let anything slip through the cracks.
Check out this brilliant decipher workflow. This is where your expertise solidifies into actionable claims. You've got your traffic green data streaming in, right? And your decipher selection is precisely routing it to this critical ticket structure. Look at this. Every claim starts with an audit ID. Here, it's 6366. That's its unique identifier, its digital fingerprint. But the real brainpower, the true COB mastery, comes in with that root cause. We're talking ROTH 002. Why is that crucial? Because this isn't just data entry. This is about identifying Medicare primacy. You're determining if Medicare or the group health plan is primary. And that leads us directly to the project field, mock pit. This is your moment to shine. Is this a working age scenario? Disability? ESRD? Which MSP rule applies here, COB Master? You are actively applying those complex coordination rules right here, ensuring accuracy. And for the CNL reason, it's other. Because every single claim has its nuances, its story, doesn't it? You're drilling down, pinpointing the exact specifics. This entire powerful process, by the way, is driven through Decipher, seamlessly integrated via your COB dashboard. This isn't just a system, it's your platform for building those impeccable claims, sending them straight to power bars for processing. How amazing is that?
Next, we're diving deep into the manual claim entry logic right now. This is how we build those crucial claim IDs, and you've got to be surgically precise. Look at this example. H160712044181928000. Every single character is a data point, telling a story. First up, that H. What is it? That's our system identifier, specifically for Highmark in this instance. It tells us where that claim originated. Next, the 16. Super critical, but simple, right? It's the current year, in this case, 2016. A quick 2-digit snapshot of the year the claim was processed. Then the 071. This is where our forensic skills really kick in. That's the epoch calendar day. It's the Julian calendar day of the received date on the claim. So if a claim was received on March 11th, that's day 071. You are mapping the exact day a claim landed in the system. How cool is that precision? Following that, we have the monster string, 204418192880. This is the raw, unadulterated claim number from the original system. This is the unique identifier for that specific claim. We just pull it straight in. And finally, to tie it all together, the 00. That's our claim iteration. Is it the original submission? Yes, if it's 00. What if it was an adjustment? You'd see 02 there. This tells us if we're dealing with the first pass or a subsequent update. You see how every part plays a role? This isn't just a number. It's a meticulously constructed data string. Getting this right is absolutely paramount for our accuracy. You're becoming a master of detail here. Let's go. Okay, COB masters, let's dive into these critical workflow status codes. You found the data, now what? Our status codes are the heartbeat of the audit process, telling us exactly where a case stands. First up, 101, new. This is your starting line. New membership, hot off the presses, screaming for investigation. We're talking fresh data, unturned stones. You see 101, you know it's prime audit time. Then we hit the jackpot, right? 513 MC Prime. Yes, this is a win. Medicare is primary. Claims are built, coordinated. This is the goal, people. You've navigated the labyrinth, you've confirmed primacy, and now we're collecting those overpayments. This isn't just a status, it's a celebration of your forensic prowess.
But wait, what about 903 waiting? You found the overlap, you've identified the opportunity, but the dollars haven't quite accrued yet. It's like waiting for the perfect wave, isn't it? The potential is there, the data's aligned. Now we just need that financial impact to crystallize. Patience, young COB masters, patience is key here. And then we have 902 in lag. This is different from just waiting for accrual. Here, we've identified the overpayments. They're locked, loaded, ready to go. But there's a lag, a waiting period, often system-driven, before we can actually submit. Are you seeing the nuances? Are you internalizing these distinctions? Because a true COB master knows the difference between waiting for money to accrue and money's there, just waiting for the green light. Get those codes ingrained.
Okay, we're at the absolute critical juncture. This is the final check, all about integrity and accuracy. We're not just looking at data, we're protecting the plan, right? You're verifying that entitlement reason. Is it age, disability, or ESRD? Why are they even on Medicare in the first place? Because that reason dictates everything that follows. Then we're drilling into employer size. 20 versus 100. Are we certain about that count? Is it 20-plus employees for worked and aged, making the GHP primary, or 100-plus for disability? If the employer is small, under 20 employees, Medicare is primary, no questions asked. Get this wrong, and you're costing the plan massive dollars. And finally, the dates. Oh, the dates. Are we confirming that exact overlap? Are you nailing those precise 30-month windows for ESRD? This isn't guesswork. If you miss a single date, you either miss a huge recovery opportunity or you incorrectly assign primacy. This isn't just about finding errors, it's about preventing them. You're ensuring accurate auditing, protecting the financial integrity of the entire plan. This is your final quality control. Make it count. Let's go.